just going to say that. So, you should have a note on your screen saying that you agree to, or that you are informed about this meeting being live streamed, and Omar will have a little bit more information about that in a second. But again, good evening, everyone. Welcome to this town hall. Hopefully more people will be able to join us today, and if not, in another time. I am Manny Santiago, Executive Director of the Washington State LGBTQ Commission, and I use any pronouns. And with that, we always at the Commission recognize that we are on indigenous lands, that we occupy lands that have been stewarded by indigenous folk for generations and since time immemorial. So with your permission, I will read our land acknowledgements as we enter to do this work. The Washington State LGBTQ Commission recognizes that we live and work in stolen lands. These lands, water, mountains, skies, and everything within them have been inhabited since time immemorial by the descendants of the 29 federally recognized tribes, as well as the many not recognized tribal communities in the state of Washington. We recognize the history of colonization, genocide, subjugation, and enslavement experienced by indigenous peoples in these lands and throughout the continent. It is our commitment as a state agency to recognize tribal sovereignty, to work alongside tribal partners for the well-being of our communities, to celebrate the achievements of the many indigenous communities among us, and to dismantle the ongoing legacy of settled colonialism, as well as the exclusion and erasure of indigenous peoples that continues today. May it be so. And with that, I will let Omar give us a little bit of the housekeeping and a couple of things that we have to keep in mind. And then after that, we will move on to introducing the facilitators tonight and the conversation. So Omar.
Thank you, Manny. As I mentioned, Omar Santana, I use he, him pronouns. I am the program manager for the commission. I will be doing a lot of the background work here on the Zoom call. Again, please note that this town hall is being recorded. It is a public event, and we will be recording for future information and access to those that are not able to attend today. If you have any issues with Zoom or access, please send me a message via chat, and I will be able to see how I might be able to assist you. Going along with the fact that it is a public meeting, in order to foster a healthy and safe interaction, if there is any disruptive behavior, the participant in causing a disruption will be notified by commission staff about their behavior. If they refuse to comply with health and safe interaction guidelines, they will be removed from the town hall. Healthy and safe interaction includes assuming positive intent on the part of the moderators, participants, and staff. Do not use transphobic, homo, lesbo, biphobic language, misogynistic, xenophobic, racist, anti-Black, ableist, ageist, or foul language during your interactions. Please keep your comments and questions on the topic. This is a town hall conversation on HIV medication access. Name calling and insults are not allowed. Thank you again. And again, if you have any issues with your Zoom, please let me know. And Manny, back to you.
Thank you, Omar. So I wanted to take the time to introduce to you the team that is going to be facilitating this conversation and following conversations after today. Yeah, so with that, I would like to introduce Renee Mccoy and ask her to share with you a little bit about her and her role in this meeting.
Hi, my name is Renee Mccoy, and I've been active and involved with HIV and AIDS since the very beginning, since 1981, in New York City, in Washington, D.C., in Detroit, and for the last 10, 11 years here in Seattle. Previously, I worked at Lifelong AIDS Alliance and as Director of Prevention and Education, and continue to do a lot of consulting work back in Detroit, and work with hard to reach populations, and in terms of risk for mostly people of color. My role in this, however, is as a facilitator, and I'm here just to take notes. I'm not I'm not wearing that activist hat or a researcher or any of that, but I'm here just to help facilitate and make sure everything works well, working with Martha Bean, consultants, and that's pretty much it. I'm here to keep the peace and as support for Manny and for this project.
Thank you, Renee. And Omar has shared the link to the YouTube channel where your connections and contacts can access this this live streaming of the meeting. And to know a little bit about Omar and his role with these conversations and the work group on HIV medication access, here's Omar. He can tell you a little bit more about him.
Thank you, Manny. Yeah, and so program manager for the commission, and so I have been in the conversations, and I don't have a specific background on the HIV pandemic or accesses to medications, but through the process, I have been learning and been meeting with stakeholders and do like you all think it is a very important issue, and making sure that we do have the best connections between our government agencies who regulate a lot of the funding and access, and then also our community partners. And so with that, my role in this is as facilitator in the background. And so again, mostly doing a lot of the background admin work. And if anybody has any issues, again, please feel free to message me.
Thank you, Omar. And as I said, Manny Santiago, excuse me. And even though I haven't done HIV activism in a while, I was trained as a peer navigator, and when I was in college, back in the day, back in my home country in Puerto Rico. And actually HIV activism was the one that outed me when my parents found some flyers and things like that, and some of the paraphernalia that I used to do education and things like that with peers around the western side of the island of Puerto Rico. So that's what I did with HIV education and activism back in college, and then since then I have been involved mostly learning a little bit more about the development of the pandemic, as well as treatment and activism, and following with the activists on the ground on the work that they were doing. So we are not strangers to this work. We all come here because we are directly affected by HIV in some way or another. And I really thank each and every one of you for your passion, for your dedication, for your commitment to ending the pandemic, both pandemics, HIV and COVID, and to work and support each other in this work. So hopefully some of you had the opportunity to look at the agenda that was posted on our website. I will be sharing with you the link to our website where we keep all the documents related to the work of the work group on HIV medication access. You can go there regularly, and we will be updating with the notes from the meetings, with the recording of the meetings, with the recording of this town hall, as well as the notes from this town hall, some the presentations from the meetings that will be coming up this week, as well as some supporting documents that you can use as a reference, even some research and links to research to learn more about HIV in general, HIV and Medicaid access, and things like that. We know that, well, today what we want to do is to have a conversation with different partners from different perspectives. And how I am presenting this is the first of a few town halls that we are going to have to get and receive the feedback from the community. So to some extent, this is a brainstorming session. There are no wrong answers. There are no wrong ideas in this particular meeting. We do not expect that any of you have read every single document produced so far by the work group. So do not worry about, I don't have anything to say about that particular issue. Yes, you do have something to say about the issue in general because you're here, you're invested in this conversation. So please do not let the fact that you haven't had the chance to look over the documents produced by the work group prevent you from sharing with us your ideas, your concerns, your thoughts, okay? So it is a brainstorming session again. We don't expect to have the final answers to anything. We just want to hear directly from the community and the different stakeholders and partners. With that also means that because there are no wrong answers or wrong ideas, that means that we don't have to defend our positions or defend our ideas or to fight some other person's ideas and concerns and whatnot. Here is an opportunity to directly hear from the community in general on these issues. A couple of other things is that so far the work group has met twice, once to get to know each other, once to review the processes and to get to know what it is that the legislature asked us to do collaboratively, and then a second time to go over some presentations, some data, some research, some specific points that we needed to keep in mind, as well as start a conversation on ideas on how to address the issues that we want to address. And what are those issues? Well, there are three particular things that the legislature asked this work group to work on to pay close attention. One, and I'm going to read them, excuse me, directly from the budget proviso. The first one is access to HIV antiretroviral drugs on the Medicaid drug formulary, including short and long-term fiscal implications of eliminating current prior authorization and fail first requirements. So access to HIV is through the Medicaid drug formulary. That's one of the main reasons why we are having a conversation with stakeholders. What do you think of access? What ideas you have for access? The second one is impact of drug access on public health and the statewide goal of reducing HIV transmissions. So what is the impact that these different ways of addressing access to HIV medication have for different populations, for different groups, for providers, for pharmacists, for government agencies, for people living with HIV and caretakers? And then the third one is to maximizing pharmaceutical drug rebates for HIV antiretroviral drugs. So how can we maximize those rebates? And in order to do that, we need to understand them more. So all of that is together. So I have talked a lot so far. And what we want to do, and this is just to set the stage, but what we want to do right now is to hear from you. And how is this going to be to work? I have, thanks to the work of Renee and Martha, I have some questions that are going to guide our discussion. That doesn't mean that we have to necessarily stick to those questions only, but the questions are going to frame the discussion and the conversation. So, excuse me, and as I said, there are no wrong answers, no wrong ideas, no wrong dreams. We are going to share what we feel. And then in later town halls, we'll come back to you to ask for feedback on products that we have produced as a work group. So today, brainstorming. Later on, we will come back to you and others to get feedback on finalized products. So the first question that we want to address today, excuse me, and Renee is ready here to help facilitate the conversation with me and to take notes. But the first question that we want to focus on is, so what do you think are the challenges? Actually, let me rephrase this and actually read from this. It is believed that persons living with HIV who are receiving Medicaid continue to face challenges to access medication, right? It is believed that persons living with HIV who are receiving Medicaid continue to face challenges to accessing medication. What do you think those challenges are? What are those challenges? How do they affect the lives of persons or people living with HIV? How do those challenges affect the lives of people living with HIV? And are some groups more challenged than others? Which groups, if you want to share that. So I will post that first question on the chat and we can have a conversation. If you want to speak, just make sure to raise your hand or give me a signal that you want to speak. I will call on you and we will listen. So we're not going to be responding. The government agencies are not going to be responding. We want to listen. So the first question, what do you think that the challenges are to receiving HIV medications through Medicaid? How do they affect the lives of persons living with HIV? And are some groups more challenged than others? And if so, how? Floor is open, folk. I see Greg. You're muted.
Hi. So I'm a client at Madison Clinic, and they've done a great job of providing healthcare to a wide array of people. So I'm speaking in terms of that environment. And I think that the people who are groups who are most vulnerable are people with mental health issues and homelessness. And that clinics like Madison Clinic, I feel they do a good job at trying to reach out to those people and meeting them wherever they're coming from or attempting to do that.
Can you speak a little bit more about the, compounding issues of, mental health and other chronic diseases probably? And what do you think that are some of the specific challenges for people to access the correct medication, the correct care that they need,
Yeah, so probably even as simple as reminders for taking their medications, like not necessarily knowing what day it is. I know for me, I use a Mediset, but I also put bottles after I take my medicine. I put bottles where I can see them, knowing that that's the next one I need to take. So I imagine if I didn't have my house where I could do that, it would be more challenging. Yeah, that's one example. I think also language. People not having English as the major language, that again, that creates a barrier. Thanks.
Thank you. Others? Feel free to share anything related to the question. So it doesn't have to be very specific. It can be something broad. This is a time to share our thoughts and ideas. Peter?
Just to speak as a provider, in general, we try to prescribe medication for HIV that is the appropriate medication for that person based on their situation. To have choices narrowed means that we can't do that. And so some of the groups that Greg was talking about, for example, let's say somebody does not have a home currently, and the formulary requires that their HIV regimen consist of 3 separate bottles of medicine, because those components, even though they're available as a single pill, that's not on the formulary. And the process to say, this person can't handle multiple bottles, they'll get stolen or lost, and they'll take part of their regimen and it will make things worse by generating a resistant virus. That doesn't fly because that's not what's in the FDA approved package insert. We don't have FDA approved recommendations that say if somebody's dealing with mental illness or lack of housing or a language barrier, that this medicine that comes in one pill is more suitable for them and can address those issues. The approval process is basically just a reprint of what's in the package insert, which is based on studies that did not look at the effect of people's lives on their ability to take this medicine. So that's kind of a big deal. There are many other issues with this current state restrictions. For example, medicines that may have more toxicity or medicines that may be more fragile that lead to the virus becoming resistant. And the concept in HIV, it's very different. They're talking about failure and then you go on to take something else. Well, if somebody's treating high blood pressure and the medicine doesn't work, you can switch to something else. If somebody's treating HIV and the virus breaks through, it's not that simple because then you've actually created a worse virus in that process. So the idea of step therapy for HIV is extremely problematic. Another group that's affected by these formulary restrictions are people who are newly diagnosed. Currently, the becoming the standard of care, and this was true in this room where I'm speaking from right now, my exam room, I dealt with a newly positive person. The standard of care is that when a person is diagnosed, that they're started on medicine that same day. To be able to treat them with a single pill, and I actually gave this person choices based on other preferences that he might have. I gave him choices of 3 single pills, none of which are on the current formulary. Instead, I would have had to give him multiple pills or a very old single pill that nobody uses anymore. And I would not be comfortable doing that. I wouldn't do it. And so people who are newly infected are affected by this process because they need to start with something more complicated than what they expect and what might be good for them. The kind of secondary outcomes, and I don't want to speak too much, but I just want to sort of say my piece a little bit and then I'll be quiet. The secondary outcome is the effect on providers. And I mentioned that to somebody. I got a lot of different invitations to speak today or to participate, but there's a big problem with provider burnout. And one contributor to burnout is that we have to beg to get the right medicine for our patients. In other words, we can't just say, this is the best thing for you. I think it will work the best with the least side effects and be the easiest for you to take. What instead we're asked to say either is, here's something that I wouldn't necessarily want to do myself, but I'm told I need to prescribe to you first. And then if it doesn't work out, we'll do something else. And then at that point, if the patient comes back and they're either confused or they're having side effects, then I have to do this fairly complicated and offensive process of begging the state using a form that's really insulting to have to fill out. And that leads to provider burnout. Now, in Seattle, I'm not sure how aware you folks are, but we've had 4 HIV providers retire in the last couple of months, 4 senior providers who are very experienced in HIV care. And I know that at least 2 of them, part of the contribution to their retiring was burnout, was the frustration and the hassle factor of doing what they would like to do. Another sort of sideline to burnout is that it becomes even more distasteful to try to navigate the public system and take care of people on Medicaid. So many of my colleagues in private practice, whatever their specialty, don't see Medicaid patients. And it's a disincentive to us if we have to actually work harder, get compensated less, and be insulted and hassled in trying to take care of our HIV patients. One of the people who, and I've been doing this for 31 years. The colleagues that retired are all younger than me. I do it because I love it, but I also feel punished by it. And one of the people who invited me to come to this meeting included a sentence that said, "Thank you for what you do." And, I get thanked sometimes by members of the community. I have never been thanked by an insurance company or a state official that says, "We appreciate that you're taking care of these patients." Instead, what they say is, "We're going to make it harder for you to take care of these patients. And you're just going to do it because you want to take care of them. But we can make it as hard as we like because we know you're not going to give up," except for those 4 guys that retired this summer. So that's it. There's a lot of emotion involved, and I'm not going to get into the emotional part, but those are just some of the reasons why I think this is a really toxic problem, and I'm glad the commission is addressing it. Thank you.
Well, thank you, Peter. And as a state official, I do want to extend my gratitude to you for the work that you do and your colleagues, and even the ones that had to retire because of burnout. Is completely okay to care for yourself. And I really thank you and your colleagues for the work that you're doing. I would like to hear more from you, so please don't feel like that was it. We want to hear more from you and your colleagues. So actually, I would like to call if there are other providers, whether physicians, assistants, pharmacists, social workers, any other provider that might want to add their own experiences with the current formulary. That would be fantastic. I would also love to hear if there's any patient that feels comfortable self-identifying as a patient. Remember that is a public live stream. But anyone that has had direct impact on access because they currently live or care for someone or treat someone with HIV, I would love to hear some of the stories and some of the challenges that you have experienced. And Peter and Greg, if you have anything to add to what you have already shared, that's also an opportunity for you. Andrew, see your hand.
Hi, yeah, I'm Andrew. So I work with the King County. We're on the HIV/AIDS Transit Grants Council. I can only speak for my community, and my point of view is when it comes to HIV and medication among the immigrant community, based on experience, is we have a lot of hurdles to break through. One is cultural hurdle, where there's a high ideology of homeopathic treatment as against getting medication. And a lot of people believe in alternate science and would not want to get medication. 2 is cultural approach to people of let me rephrase this, the lack of cultural education among providers. And in terms of providers, I talk about the clinical providers, the social service providers, and even organizations that provide services to that community. There is a huge disparity on understanding culture. And I really think due to that, people are not really open to go and seek their medication. And going back to what was said earlier on is language. Again, I can only speak about my area, King County. In the south of King County and some areas of King County, we have people that don't speak either English or Spanish, but publications to try and get to them and give them resources lack their language, and that most people would not be able to access. And then again, affordability. Through Ryan White, the EIP works in a way, but as the budget requirement, I mean, the income requirement for the EIP, I think is outdated, because it's like if you earn a certain amount, you qualify. But the impact of inflation and all that is not really added to that gross income. And certain people that cannot afford their medication on the co-payments, but they don't really qualify at the same time for EIP. And therefore it's a struggle. What do? They have to deal with bills, rent, or medication. And those are things we need to look into. And I've walked that road before. I've walked that road before, and I understand the struggle.
Andrew, I would like to ask you if you can or know of, in addition to language barriers for immigrant and refugee communities, in addition to cultural competency on the part of providers themselves, do you think that there's an impact, cultural impact, when it comes to government process, right? So by that, I mean, different jurisdictions, different states, different countries provide HIV medications or treatment differently. So have you seen or have people share with you some of the challenges that they might be facing because the system itself is so different than what they might be accustomed back home? Have you heard stories about that, or is that a thing right now, or is not relevant?
So let me try and say, so when we look at HIV/AIDS as a whole, and a lot of these people struggle with stigma based on their ethnicity, culture, and origins. And that also affects the way they seek help. And I think, okay, like in Nigeria, let me use Nigeria as an example. HIV medication and treatment is not as discreet as it's supposed to be. So when people like that come to the USA, they are scared of people knowing. So it's also, and that's why it goes back to educating providers on cultural education of providers. And it's something I always complain, which is very, very lacking. I'll give an example. I had someone that was of Brazilian origin and discovered, and all the resources from the providers and everything, they kept on sending him to Spanish. And he's like, I don't understand any of this. And they had nothing in Portuguese or anyone that understood his culture. And for a while, he was like, okay, what should he do? And I said, don't worry. And we tried to work together to help him get something that he could relate with. And I think one of the key is finding something relative that they could identify with. And when we're able to break down and understand and get that identity that people are looking for, and use it to educate them, use it to reach out to them in their own manner, I think a lot of people will be able to get more access and be able to take more to be able to get the medication and the treatment they need. And also on the economic impact, as I said, the EIP income level doesn't reflect inflation. And as someone that has been affected by that, is something that should be looked at.
Thank you. For the people who have joined in, we are going over a few questions to lead our discussions. I said there are no wrong answers. This is a time to hear and listen from the community itself. I will post the questions that we're considering right now. I will post them on the chat so you can read them. There they are. Excuse me, we are having a conversation. Feel free to raise your hand or give me a signal. I can see pretty much all of you on my screen. So if you want to speak on any of these questions right now, please raise your hand, let me know. We will continue working on the challenges to accessing medication through the current Medicaid system and the systems that are currently in place. So feel free to jump in if you have a comment or concern, questions, ideas, stories. Alex Barnes, please.
Yeah, hi there. Hang on, let me get my video to work.
It's okay.
Hi, I'm Alex. I'm a case manager, a medical case manager for people living with HIV. And I specialize working with folks who are incarcerated or recently re-entering. And I just want to say that this really does disproportionately affect our incarcerated populations, because oftentimes when folks are entering, it's unfortunate, but it's an opportunity to get folks onto treatment. But when they leave because of Medicaid, they're often, like as Dr. Shallow pointed out, on a 3-pill regimen, which is really difficult to try to manage when you're re-entering and you don't have a phone, a house, income, or anything like that. And so when I'm looking at drivers of HIV and the epidemic and stuff like that, this is a population that continues to be overlooked, and it's a population that are high users of Medicaid. And so I think that if we're going to address some of the barriers, I'd hope that we don't forget our incarcerated folks as well.
Thank you. So important to keep that in mind. Any other comments, any other challenges that we can identify from service providers, service organizations, stories that are important for us to hear? And if you don't have if you're like me and don't know much about Facebook, just unmute yourself and say hi. I see Steven Sawyer, Commissioner Steven Sawyer from the LGBTQ Commission, by the way, and Pocan.
Hello. Yeah, I think it's really too important for us to think about, particularly communities of color, right? Who are definitely most affected by new HIV infection rates. But like has been said before, have a lot of things going on. You know, housing, employment, other issues that make it difficult for them to manage a multi-pill regimen. And I think we have to, do some myth busting in the sense that so often, and we fought against this notion that, they're not gonna be adherent if we give them one pill, right? Which makes no sense. I think it makes it a 1-pill regimen makes clients, it makes it much easier for them to be compliant in that regimen than it would to manage 3 pills, who often each pill has its own area of things that it might have. Some you might have to eat with, some you don't. And I know we made some tremendous advances, but a 1-pill regimen works better for the communities that we know now suffer the biggest burden of new HIV infections. And if we are going to be true to the idea, if not the plan to end HIV, we really have to address that and make the best tools accessible for those individuals that we know are most affected.
Thank you. So let me just to clarify, there is a perception that if a person with difficulties understanding or accessing a regimen, there's a perception that if you have more than 1 pill, it'll make it easier for them to process the fact that they have to access or to take pills, right? Whereas if it's only 1, they might forget. And what you presented is that the opposite is actually true, that it's easier to manage adherence if it's 1 pill than having multiple pills a day. Is that what I heard?
Yes.
Okay, thank you. I wasn't aware of that, so it's good to hear what is thought out there. Okay, folk, I would like to move to the next question, and we can always come back to the first question if you have an idea about the first questions that we posed. So feel free to go back and forth. But I'm actually going. Yeah. So this question is focusing on the future and focusing on what would work. We have, shared what the challenges are, some of the communities that are experiencing more challenges than others. Now we want to hear what are possible solutions. And again, this is a brainstorming session, so every solution will be put in paper right now, because we want to hear what are your ideas. You who are working directly with the population, you who are living with HIV and accessing medication, you who are working in some form with the population that receives Medicare, Medicaid. What are some possible solutions to this? And on our part, again, we are not defending or anything like that, the current systems. We want to hear right now, what are some possible solutions, so we can bring this back to the work group and then, workshop with them on the possible solutions that we will present to the legislature. So what are some solutions that you can see to these challenges to access? And I think that I want to actually summarize what Andrew earlier said, the challenges of language. So we can take that, right? Like providing more printed documents and printed literature in different languages, having cultural competency for providers, things like that. So what other possible solutions? And yeah. Here's the time to be creative, folk. We can imagine that you have the keys to change this in a way that makes sense to you. What is that way? Feel free to share that with us. Nobody's going to be offended. Nobody's going to be like, no, that cannot happen. Right now, we want to imagine that it can happen. So, so please share those ideas and those thoughts with us. And Francisco, Carlos, I see your message. Veo tu mensaje en el chat. En un momento lo atiendo, okay? I'll be going to the chat in a second with what it was shared right now in Spanish. So. Ideas. Yeah, Peter.
So thinking about the carrot and the stick, right? So the current program is the stick. There's no carrot. There's no reward, and there's no sophistication. And this is an example where people are looking at a drug budget without looking at the total cost of care. And so this is sort of a vague suggestion, right? But I would propose that the total cost of care would not increase if the formulary were liberalized, and perhaps some other incentives to providers, prescribers, clients, affected communities to keep costs down in ways other than prohibiting certain medicines. For example, guidelines, the labs that we get, encouraging providers to keep up to date with education about HIV treatment. I mean, there are things that we do in our practice. I think our folks that we take care of with HIV cost less than they might in some other systems because of how we do things. And rather than just looking at the ticket price of the meds, looking at the total cost of care, and encouraging providers, giving providers incentives to reduce cost in ways that don't harm patients. That's like too simple or too complicated, sorry, for a bureaucracy to do. It's much easier to say, we're just going to cut the most expensive meds out of the formulary in order to keep our budget down, but to look more in a more sophisticated way that actually is positive rather than negative, which is kind of the way the current strategy has gone.
Thank you. Carlos, from the chat, ¿quieres decir algo? Yo te puedo ayudar a traducir. Te veo. ¿Estás en mute todavía?
Buenas tardes. Mi nombre es Carlos Delgadillo. Gracias por la oportunidad que presentan al público. Y llegué un poquito tarde, lo siento, y pido muchas disculpas. ¿Puedes traducir?
My name is Carlos. I am sorry that I came in late, but thank you so much for holding this space for us to share. Dale.
¿Puedo decir lo que sea o tengo que seguir algo?
Pues tenemos las preguntas, hasta ahorita las dos preguntas principales que estamos considerando son, la primera, ¿cuáles son los obstáculos que la comunidad tiene para accesar los medicamentos a través del formulario de Medicaid? O sea, la primera. Y la segunda es, ¿cuáles son algunas ideas que puedas tener para cambiar la forma en que se accesan los medicamentos en este momento? I'm just explaining what the two main questions are for the discussion.
Creo que mejor hablo después porque todavía no tengo una muy buena idea de lo que está sucediendo.
Ya.
Regreso, bueno, voy a estar aquí con ustedes, pero mejor más tardecito, ya cuando esté más al 100% seguro de lo que están ustedes platicando.
Ya.
Gracias.
No hay
Aquí voy a
problema.
estar.
Claro. He's going to take some time to think through for his answers to the questions so he can formulate his answer and his suggestions. So he'll be around and paying attention to the conversation so he can have more to share with the group later during the conversation. Okay, folk, we are still receiving some comments and ideas on how to address the challenges of access. So please, what other ideas do you have for us? And again, there are no wrong ideas. There are no wrong answers. There are no wrong, dreams. We want to hear what ideas you have so we can start working on them. Commissioner Maroon, I know that you mentioned, you affirmed some of the comments that Peter made. Would you like to speak a little bit about some of your ideas, Everett?
Thank you very much, Manny. In addition to being a commissioner on the LGBTQ Commission, I run a nonprofit, Blue Mountain Heart to Heart in Walla Walla, Washington. That is a Ryan White Part B provider. So, we've supported people living with HIV/AIDS for 36 years and counting. And I agree that, the question of overall costs should be something that the state is looking at with regard to medication support for clients on Medicaid. Once upon a time, we were looking at the state was looking at cutting HIV prevention dollars to syringe programs, probably around 2011 or 2012. And I noted that cutting our tiny $20,000 a year budget would be totally undone with one new case of chronic hepatitis C, because the cost to treat and cure that virus is about $80,000. Then the state relented and decided it was worth it to continue to give us the small $20,000 contract. This is really not very different. And the only other thing I would note about vulnerable groups, in addition to who's already been noted, is that in Eastern Washington, we do tend to see later diagnosis. So I have had clients on my caseload with CD4 counts of 59 at diagnosis, of 100 at diagnosis, and one person with a CD4 count of 1, which I had thought was 4, but was later amended. It's really hard to say to somebody when they do have a late diagnosis, when they already have lymphoma, they already have a cancer, some other kind of cancer, they already have other chronic diseases that they're battling, that we're going to put them on a 3-pill regimen. they may already have 14 other medications that they're trying to deal with. They very, very rarely are only taking an HIV antiretroviral medication. So one of the reasons why I really wanted to affirm the doctor was to say, yeah, our healthcare costs in total are really at issue here. And when people are more poorly managed, or when they feel so much stigma that they're afraid to talk to their physicians about what's going on with them, that's when we start to see a lot of hospital visits, a lot of urgent care visits, a lot of diagnoses that are very expensive to treat. So it's really short-sighted to say that we're just going to make this decision based on medication only. It's not the way I see things play out again and again. And I just don't want to have to look my clients in the eye and say, yeah, we won't give you a simpler regimen because of money.
Thank you. Thank you for sharing. So important to hear the stories of people on the ground who are using these systems, right? And who are seeing the patients themselves and who are doing the work of keeping our community safe and healthy. Renee.
Yeah, I just want to encourage people. We have the things, some of the things that have come up tonight are things that have been coming up that have, that have been presented as obstacles to care and to access as well as impact for years, perhaps the last decade. And I would encourage people, this is things like stigma, things like language, things like the need for cultural competency. This is an opportunity for us to present to really make some recommendations. If you think about this, think about in the best of all situations, what would you do if you didn't have to worry about money, if you didn't have to worry about anything? What can we realistically do, or not realistically do, but what can we do about stigma? What can we do? What's really going on? And I think that that's the answer, and what really needs to go on if we are going to increase access. Y'all seem just be defeated before you're defeated. This is not a time to look at defeat, but to look at possibilities. So what would be the best possibilities? We have not because we ask not, kind of thing. What would we ask for?
On the chat, Lori shared some great ideas, and I would like to invite Lori to share those ideas out loud if you feel comfortable. If not, I can read, but would you feel comfortable sharing those ideas with the group so we all can see it? By the way, the people outside that are watching at the live stream, they do not get to see the chat. So just so people are aware of that. Lori, yes.
Yeah, sure, I can do that. Oh my goodness, let me go find the road now. Basically, I think that there are really a number of things that we can do. I think that some of it's about providing just basic information to people in really digestible form, like in infographics, things that don't require a lot of time and effort to read and understand. And I think some of it we need to be doing in person, whether that's via Zoom because of the pandemic, or whether we can actually be face to face with people. But I think meeting with the legislative committee that sets healthcare policy, meeting with folks at HCA that are making the decisions about what's on the formulary and other kinds of healthcare policy is an important thing to do. And I think we should get leading clinicians and researchers, as well as people with HIV who can share their own stories about, what is the impact when we can't do this, looking at how are we actually widening the health disparities that we already know exist and who is hurt the most by these policies. And if we look at the whole federal ending the HIV epidemic initiative, we know that we need to reach out to the most vulnerable people who are the least able to successfully engage in care and achieve viral suppression. And we need to make it easier for them, not harder for those people to be able to access and take their medicines. I think there's lots of data out there. I think if, thinking back on when the first study was done that showed that paying a lot of money for these very new expensive combination HIV meds back in the 90s came out, showing that, the drop in hospitalizations well set off any pharmacy cost. And so I think if we were to look at, well, what do we have now? And what, get a health economist to do some of that analysis today, showing, what is really the impact when you have a formulary that doesn't allow people to have the best care. Washington was an early leader in HIV. We had, many people say we had the first needle exchange program, depending on what you consider the first needle exchange program in the country. We did early PrEP research. Why would we want to really lag behind when it comes to providing clinical treatment to people? We really need to do a better job of some of these things. And I would point out, this is what the IAS recommendations are internationally. This is what the DHHS recommendations are nationally. I mean, they are specifically recommending these combination 1 pill a day kinds of treatments for people who are able to take them. So why would we want to be out of step with the national and international recommendations, which don't differ from each other very much? And I think you can really narrow the circumstances under which you would need to get prior authorization. But, I think we should be sharing vignettes and people's stories and all the ways in which, this is, penny wise and pound foolish. And I think we have enough history of these kinds of health policies that really harm people and don't allow them to get the care that they need in order to stay engaged in care, in order to avoid transmission to other people that they may be either sexually active with or using drugs with. So both from a treatment and a public health prevention standpoint, it's in the state's interest to cover the best medication available. And soon we're going to be, sorry about that. We're going to be having, long acting injectables, which I'm sure are going to be expensive, coming online. And what are we going to do about making those available as well? Because for some people, that's going to make all the difference. So I would focus on some of those kinds of things.
Thank you, Lori. Those were really great points, really great ideas, really dreaming big and dreaming together. So thank you so much for sharing. There were two things that you mentioned, Lori, that I think, I don't know if anyone wants to say a little bit about these things, but one is sexuality and engaging in sexual behavior. We know how HIV transmits, and one of them is through sexual, sex. And some of the challenges that I can see from my perspective is, working with the LGBTQ Commission, right? But one is that the taboos around sex and sexuality in general, and how we use those to block people from enjoying sex and engaging in sex in general, which can also be through, not allowing people the care that they need or that we all need. So that's one. The other thing that I heard was drug use and how that affects the transmission of HIV. And it's another taboo that we don't want to talk about when talking about these issues. So thank you, Lori, for mentioning them, for naming those things, for making sure that we take all of our humanity when talking about these issues. So thank you. I really appreciate you mentioning those two particular things in this conversation.
Thank you.
Other ideas, let's think big. Let's think about, what are we doing collectively to make sure that people have access to the care that they need and deserve. I know that there are many ideas. I've talked with many of you about these ideas. I want to hear them. And that goes to everybody. It's pharma representatives, physicians, other care providers, people living with HIV, service agencies and organizations. What other things would you like to share as possible solutions to these challenges? Renee, yeah.
So far, the focus of our conversation has been making, a major focus of our conversation tonight has been making sure that people can have, that access to medication is made easier by moving from multi-tablet to single tablets. What do y'all feel that is the only issue, that if during this process we come out of this process, the legislature does what it needs to do, and all of a sudden it becomes all right to give everybody one pill? Because that seems to be the focus that everybody's thinking about. Is that the issue, or are there more issues? Because that seems like a doable recommendation. Just move from multi-pills to one pill. I think it's bigger than that, and I think what people are saying is larger than that.
Mm-hmm. Peter?
Yeah, it's definitely bigger than that. Some of it is toxicity. I mean, I again, I'm going to mention a drug name, but AAA. I had a conversation with one of the gatekeepers at the state about a patient that was denying my prescription, and they suggested that I use AAA. So AAA is an outmoded drug, and it's insulting to have that be a preferred regimen. It's associated with an increased risk of suicide, anxiety, and depression, and we shouldn't be prescribing it. And to have that be encouraged. So the current guidelines, it's not only about the complexity of the multiple pills, but it's about the toxicity. And some of the regimens that they're recommending that are generic, the reason that we don't use them is not simplicity so much as toxicity. We're trying to not harm our patients, and we're being asked to harm our patients. So that's another one. When I talked about burnout, that's sort of a downstream effect, in that the more hassles that you put in the way of a well-meaning provider, the more likely that at a certain point they're just going to run away screaming and either do something else or leave the field. This is just, it's death by 1,000 cuts, and this is just one of many of the 1,000 cuts that the providers are feeling. So, and I agree with Renee. There are many considerations besides the number of pills. Those are just the first couple that come to mind.
Thank you. Everett.
Well, I was just going to add on to that, which is, there are many things the state is tasked with doing, and it's all complicated when we're talking about healthcare. But one of the things that I think is helpful for us in the field to rely on is when we're following best practice. And if there's something going on because we're always making strides no matter what the health condition is. There are people out there contributing to the science, and someone mentioned long-acting shots earlier. Probably those are going to be very expensive, but for a certain segment of clients, they're probably also going to really help with adherence. And if that winds up being a best practice, then I think the state is hard pressed to say why it wouldn't follow a best practice. So, we already have some ways of addressing or at least identifying if we are in step with where we want to be. So I just don't know why we can't just continue to follow the evidence. In fact, I don't know of a state contract right now that lets you do your work without saying that you're following the evidence base. So I think our medication schedule should follow the evidence base as well.
Thank you, Everett. And I saw Lori and then Stephen.
Yeah, I agree with what was just said. And I used to live, I've done this work in a couple of other states where the policy was if the FDA approved the medication for HIV, it was going on the Medicaid formulary. It was really that simple. And really, I think to Renee's point, what is it we really want? I think that's what it is we really want. I think being able to get combination medications without prior authorization is a good step forward. But that's like a base run if you know baseball metaphors, as opposed to a home run, which would be being able to be able to prescribe anything that's on the formulary. I mean, that's FDA approved. There already is an evidence base for anything that gets approved, and we need other ways of balancing out the Medicaid budget than denying people access to what is clearly best practice, best clinical practice for getting the best clinical outcomes for people. And that should be decided by the clinician and the person in care. So that's how I feel about it.
Thank you, Lori. Stephen.
And I agree with what everyone has said. And I think getting to Dr. McCoy's point is that I am so tired of fighting these battles, because so often what happens is the people who are making these decisions are not in practice, they're not affected, right? And they have no relationship to the issue that they are debating, right? Because if people were in the room that were affected by this, were helping to make that formulary, we wouldn't be going through this. So I think for me, my broadest hope and desire is to find a way where we can put voices and people in the rooms where those conversations happen, and give them some decision-making power when it comes to their own health. I think we have to start to think at that level.
Thank you, Stephen. Excuse me. Oh, excuse me. So, sorry, I was distracted with some chats, but I want to move on to the last two questions that we have for today, because we only have 15 more minutes and we want to make sure that we do some final things here. But there are two last questions that I want to, that we, the facilitating team, wants you to think about and to share some thoughts on. So the first one is, if nothing changes within the system, the current system, excuse me, if nothing changes within the system currently in place for persons living with HIV who receive Medicaid, what do you think will happen? So if nothing changes right now, what do you think will happen? And then the final question is, what are the issues that impact the quality of life for persons living with HIV who receive Medicaid? Again, two questions to consider. If nothing changes within the system currently in place for people living with HIV who receive Medicaid, what do you think will happen? And second, what are the issues that impact the quality of life for people living with HIV who receive Medicaid? Let's have a 10-minute conversation about that to hear your concerns. The questions are on the chat right now. Excuse me. And then after that, Renee is going to share some things with us and we will share some other information. But on those questions that we just posed, if nothing changes, what would happen? And then what issues what are the issues that impact the quality of life for people living with HIV? And I think that raised hand, Stephen, is from earlier, right? Just to make sure.
Yes.
Okay.
But if nobody's gonna go,
Go ahead.
We have to be very careful here, right? Because to me, when we think about this and we think about those individuals who have to access Medicaid, Medicare, you're talking about an underserved population already, and you're making a second-class citizen, right? Because I don't have the financial means to have the #1 insurance, then I have to get a second-tier medication. When we know that there are so many other things that are already stacked against me, and I think it's not fair. I think it's not right. I think we need to voice it as really it's a social justice issue. As well as a health issue. And so we have to be careful in that. We have to be careful that we're not telling people that you can only access, a second-class health system by giving them these medications. One of the things is I had a friend also who was on atripula. It was horrible. They had horrible dreams, nightmares, and that was some of the light side effects to that medication, right? Dizziness is in the morning, could barely walk. And this was in some of the earlier days, and they refined that medication some. But we have to be careful that we're not making second-class citizens, and that's all I'll say about that.
Thank you, Stephen. Others, Greg, did you have your hand up or was that some other?
Yeah, I just kind of echo what Lori stated earlier or wrote about Washington being in the forefront with HIV and the risk of that falling out of what's happening, which I would not want to see, obviously.
Thank you, Greg. Any other comments, responses to those two questions? What would happen or what would be the impact if nothing happens with the current system? And what are the issues that impact the quality of life for people living with HIV? Carlos?
Sí, gracias. Si no cambia nada, yo pienso que, si no cambia nada para ser positivo, yo pienso que va a haber, la gente va a vivir menos años o menos tiempo si nada cambia.
So, déjame traducir. If nothing changes with the current system, excuse me, he believes that people would live less years, fewer years, and people's lives will be affected, quality of life will be affected.
Y entonces la gente va a vivir menos años o menos tiempo. Eventualmente la ciudad, el estado, el gobierno se va a dar cuenta de eso y pienso que el gobierno, el estado, las personas encargadas van a tratar de remediarlo.
So he also states that, excuse me, as people die younger because they have less access to medication through these challenges and systems, people will notice the loss of lives, and then the government would then act to prevent loss after losses have failed.
Entonces, para evitar que todo esto pase, yo pienso que el gobierno debería de trabajar más cerquitas con las agencias pequeñas que tienen case managers. Muchos de estos case managers no quieren trabajar y representar a las personas que viven con el virus. Ese es otro problema. Entonces, yo pienso, si todas las personas encargadas, las personas que dan el dinero a las agencias pequeñas, si esas personas se enfocan en vigilar cómo trabajan las pequeñas agencias, la gente va a tener una mejor vida. ¿Puedes traducir?
Yeah. So if the government pays attention to the small agencies that are working directly in providing services to people living with HIV, things can improve. So Renee, there's an idea there. If the government works directly with the agencies and support them financially and with other resources, people would have better access to medication and to quality of care. Hubo otra cosa, Carlos, que dijiste al final y no me acuerdo, además de trabajar directamente con las agencias y proveerles recursos. Oh, de los case managers, no, okay. And then the other thing that he mentioned, I forgot, I was just asking and then I remember as I was asking him. But the other thing is that there are instances where case managers in those agencies not only don't have the resources, but they don't have the desire to work with the community. And that's an issue that in this case, the agencies have to pay attention to and the state pays attention to in order to provide the best, the best resources for that agency.
Algunas agencias chiquitas que el gobierno les da dinero, un case manager tiene alrededor de 100 personas, es un ejemplo. Hay otras agencias más grandes y un case manager trabaja con 30 personas y este case manager no quiere trabajar, no quiere hacer nada por la persona que están viviendo su vida con el virus. Entonces, estas agencias que se rehúsan a representar a sus trabajadores, el gobierno debería de estar ahí con una lupa dándolos para que la vida de las personas viviendo con el virus sea más fructífera, más
fructífera, sí. So the last thing that he points out, that Carlos points out, is that there are small agencies providing direct services to people living with HIV, where the case managers have a caseload of 100 or more people per case manager. So that's a big challenge, and that the government should pay attention to how to best resource those small agencies. And then he also speaks from experience, where he has experienced larger agencies with more resources, where the case managers have a lower load of caseload. And those case managers are not necessarily invested in providing the best care. And he believes that one idea would be for the government agencies to have a closer look at the quality of services provided by those agencies that oftentimes are cheered because they have, fewer caseloads per case manager, but actually are not providing the best attention to the clients. So, gracias, Carlos. Thank you so much, everybody. We are almost out of time, and we do have a couple of things. For those of you who have shared some ideas and comments on the chat, know that we are saving the chat to go back to those to those ideas, to make sure that we represent these ideas well on our reports and our conversations with the work group. So I'm going to call my colleague Renee to give a summary of some of the things that we have heard. And then after that, Omar has some information about important dates that we want to share with you, so you continue being engaged. Renee.
Okay. Yeah, I want to point out that we will do a more in-depth summary of what y'all have presented this evening, but it may seem a little disjointed, but you've actually provided a lot of information. One of the things was that efforts to provide appropriate medication have been thwarted by the formulary and the requirement that certain things that certain medications are given out rather than appropriate medication. the FDA guidance doesn't consider how life issues impact the ability to take one's medication. For example, that the formulary doesn't take into consideration that meds, that there may be other things like homelessness, like not having the right nutrition. Another thing that was talked about was that there are some medications that may be more toxic than others to persons with certain medical issues. And so it will be important that that when we consider what the challenges are, that we consider the challenges of toxicity, that step therapy, that fail first stuff is problematic for people, and absolutely is a barrier to care, both for the person living with HIV and for the people who are trying to provide care for them. Another issue was that newly diagnosed persons may be put off by having to take multiple medications. It's enough for them to have to deal with having all of a sudden realizing that they have a disease that is going to complicate their lives, but then to add another dimension to their care by having them have to take multiple medications and to complicate their own care puts them is off-putting for them. It also increases risk for the community as well. And so what you've talked about this evening is framing medical access to medication within the context of prevention as well. It's not just about care, but it's about care and prevention. It was pointed out that there is a secondary outcome of the struggle to just get care, and that's provider burnout. It is dehumanizing and insulting for people who are trying to provide care in an underfunded climate to have to beg for the resources that they need to provide that care. And it's offensive and it's insulting for people who are care providers. And I would sort of add a little caveat with that HIV, the stigma of HIV is one of the reasons that it's so hard for people who are trying to receive care, to give care, to receive care. I don't see that, or we don't see that with any other illness, but it's that stigma, and that it's insulting for care providers to have to navigate the system, the Medicaid system, that we're beginning to lose qualified and dedicated care providers because they're just being abused by the system. It was pointed out that the immigrant community is also one of the issues for the immigrant community is having to jump through cultural hurdles, that things like not recognizing traditional treatments and traditional culturally specific care, that providers that do provide care sometimes lack cultural sensitivity, and that creates a barrier for people as well, and lessens the willingness of people who are living with HIV to take the drugs. Income levels that are set up as requirements are not realistic, and that the experience of having HIV here is maybe different from what they do at home. I need to point out too, though, that there are a lot of people in the immigrant community who were diagnosed here in this country, and they still face the barriers of stigma. Another population that we need to really consider in an aggressive way is the incarcerated community, and that upon re-entering society after any period of incarceration, people are faced with fewer resources, and that becomes even more complicated if they have to deal with multiple doses. They don't have a place to live, they don't have the appropriate living conditions, and then there's just one more layer. The bottom line is that people who are, and there are some of the solutions that people were presented was to get rid of the myths about adherence, that we need more information about what adherence really is. And that we have to understand that there are other issues beyond having to take multiple pills that make access more difficult. The other thing is that people are looking at a drug budget when we should be looking at what it takes to provide quality care for individuals, and that we should consider the total cost of care rather than focus on the cost of medication. Toxicity of medication is really not considered when we're looking at simplicity is not a consideration when they're looking at simplicity of medication. If nothing changes, and a lot, like I said, there will be, you guys said more, but we're running out of time. If nothing changes, the bottom line is that those who are underserved already in other areas will experience lower self-esteem, that this is not just a medical issue, this is a social justice issue, and it's just not about medication. If nothing changes, we will have the quality of life will continue to get lower. I want to point out before I end that what we've seen here tonight with Carlos is a real good example of how we are challenged by this. We should, we were not prepared to have to translate, and thank God Manny knows Spanish, but this is the reality that there are people who are not having to speak just Spanish, but people who are having to translate their entire lives in order to get care. And that has been the bottom line, that people are having to translate their lives in order to live. What happens if we don't pay attention to what's going on? People will continue to die. The quality of life will get lower, and people will continue to suffer with this. Like I said, we will have a more detailed report available within the next few days. But thank you so much for giving what you gave, and you gave more than I said. So, all right.
Thank you, Renee. I'm always ready to translate, believe me. It's the reality of those of us who live in two worlds, right? And I also see Omar could have translated too, and I see Dennis that was here too. So we were ready.
But what if they were speaking Swahili?
Yeah, and other languages, exactly. And
Right.
and those are some of the challenges, and it's great that we had the opportunity to actually demonstrate some of those challenges. So thank you so much. Omar, you have some information for our community?
Oh, there we go. Thank you, Manny. Yes, and so looking forward for future meetings. Let's see here. I'm going to put it in chat as well, but it looks like for a town hall, our next town hall is scheduled for Tuesday, October 12th. That is the only other scheduled town hall, but we are looking at the possibility of including another town hall before November to get some more information from the community. Regarding our stakeholder meetings, we've already had 2 meetings as previously mentioned. Our next meeting will be October 4th. That would be our 3rd stakeholder meeting, and our final scheduled stakeholder meeting, thank you, is scheduled for October 25th. More information will be made available on our website, but like I mentioned, I will be posting it in our chat now. So please, if you have any questions regarding this, please feel free to reach out. I will put my email in the chat.
So folk, the stakeholder meeting, October 3rd, and the links to the meetings are available on our website. And the agendas are made public a little bit earlier than the meeting, so you know what we're doing. The meetings are 9:30 to 12 to noon, the stakeholder meetings, and then the town hall October 12th is the next scheduled town hall. That would be the same time. So it's Tuesday, October 12th from 5:30 to 7 p.m. And again, the notice is going to be made public, and you can share that notice with everybody, as well as the link and things like that. We try to keep some restrictions on accessing, just not because we don't want people to access it, but because we don't want hackers to come into the meeting, because the commission has had some experiences with hackers taking over some of our meetings. So we try to keep it as available as possible, while also trying to keep the community safe from anyone that wants to attack the community from outside. So thank you so much for tonight. Omar shared his email there. You can email him directly if you need a follow-up or if you need more information. I really appreciate the time the fact that you took time to share with us tonight. Check out the website regularly. We will keep posting things there and updating the information. Also, you can reach out directly to me with any ideas or recommendations or concerns that you have. We will continue doing the work of the people, because that's what we are here for. So have a great night, and thank you again, and I look forward to the next conversation.